started. So just a few brief announcements. If you have any questions, the best way to ask those is to type it into the question box, which is kind of about 2/3 of the way down on your toolbar or the control panel. If you put it in there, I can go ahead and ask those for you. So you can also, if you're unfamiliar with that, I will be checking the info@natfonline.org email address. So you can also email your questions to that email, and we'll be monitoring that as well. So this evening, we are really fortunate to have Dr. Geoff Barnes with us again. He has previously joined us, and he always does such a wonderful job, as we can tell by the recordings of his support group, I think being some of the highest viewed that we have. So we're really lucky to have him with us again. He is from the University of Michigan, where he is an assistant professor there, and he's a cardiologist and also works in vascular medicine. So Dr. Barnes, thank you so much for joining us this evening.
Great. Thank you, Catherine, for having me. And thank you, everyone, for joining this evening. I'm really excited to chat with this group tonight. I was asked to talk about a topic of recent trials in venous thromboembolism. So we're going to go through a few of those tonight, and then I'll be happy to answer any questions towards the end. As always, it's important to know any disclosures, and I do have some grant funding as well as I do some consulting work for different companies that make anticoagulants as well as some of the drugs that reverse them. So just important that everyone knows that in full transparency. This is such a well-informed group that I was thinking about what best to talk about, and I thought I might hit on a couple different topics this evening. I think what I'll do is I'll start talking about how we diagnose and manage some of our patients who have acute pulmonary embolism and some of the new data and sort of strategies that have come out, focusing on two studies, the PROPER study and a treatment study on how we can treat people in the outpatient setting. Then I'll shift gears a little bit and talk about the problem of venous thromboembolism in patients with cancer, focusing on two areas. One is how can we prevent people from developing a DVT or a PE if they have cancer? And then secondarily, how do we treat it if people actually do develop that DVT or PE? So that's what I'm going to try and get through in the next 25 or so minutes. So let's start out with the challenge of diagnosing and some management strategies for acute pulmonary embolism. You know, many patients are diagnosed with pulmonary embolism in the emergency department. They often will come in with some non-specific complaints, things like chest pain or discomfort in their chest or feeling short of breath, which are really important and often very scary symptoms, but aren't always linked with one clear diagnosis. There's lots of things that can sort of cause that. We as doctors are trained to think about, well, what's the probability of somebody having a PE? And if that probability is pretty high, then we often go straight towards doing a CT scan to look for that PE. But if the probability is low, we think it's unlikely they have a PE. We'll often do a test that's called a D-dimer. This is a blood test that helps us figure out whether or not somebody is building up clot in their blood. It's a really useful test, but it's also a non-specific test, meaning it's not just for patients who have a pulmonary embolism or a deep vein thrombosis. There are lots of reasons the D-dimer test can be high. So sometimes it's positive even if the patient doesn't have a DVT. And so some people started to think, well, if these CT scans are so good at finding a PE, why don't we just do them on everyone? And there's some good reasons not to do that. The first is it can get pretty expensive to do a CT on everyone who comes in with any sort of a chest pain or shortness of breath complaint. There's also exposure to radiation every time you get a CT scan, and you have to use some contrast dye. And in people who have poor kidney function, that can really be a problem. So we need to be careful about who we choose to do these CT scans on. A number of years ago, there was this rule that was developed called the Perc Rule, or the Pulmonary Embolism Rule-Out Criteria. These are a number of different things we can look for when a patient's in the emergency department to decide how likely it is that somebody may have a PE. And if somebody has none of these, if it's a young patient, if their heart rate is pretty well controlled, if their oxygen levels are pretty good without needing any supplemental oxygen, they're just breathing room air, if they're not having any other things suggestive of PE, then it means it's really unlikely to have a PE, and we don't even need to do any imaging testing. So the question really was, can we use this Perc rule to avoid the need for any D-dimer testing, that's the blood test, or any CT scans when patients come into the emergency department? And so the study was put together using 14 different emergency rooms. 7 of them, half of them, went about doing sort of the usual thing, which means somebody comes in, we'll often order a D-dimer test, that's the lab test, and then if it's positive, we'll order a CT scan. The other half of the emergency departments, they use this Perc rule. And the question was, could we actually avoid CT scan and still provide high quality, safe care for patients? So these patients were all followed for about 3 months. And we looked to see if they had any clotting events, how many CT scans they required, how long they stayed in the emergency department, and how often those patients were admitted to the hospital. In total, this study looked at just short of 2,000 patients. Their average age was about 45, and the most common reasons people were in the emergency department was because of chest pain or shortness of breath. Right off the bat, they found that in the hospitals that used the Perc rule, fewer patients received a CT scan, only 13%. That's compared to 23%, about a quarter of patients who were in the usual care group. That's the group that often used that D-dimer blood test. So right away, we know that using the Perc rule means fewer CT scans. This graphic here actually came from the authors. They sort of tried to summarize the main results. What they found is that they had about the same number of patients who developed a symptomatic PE or DVT over the next 3 months. So overall, safety-wise, things were pretty similar. They did find that there were fewer PE events diagnosed in the emergency department when they used the Perc rule. Over here, that's a fewer number than this side. However, the standard care group, what they often found were really tiny pulmonary embolus, what are called subsegmental PEs. PEs that in some patients we're not even sure we need to treat. It sort of raises that question. And most importantly, they found that patients were able to leave the hospital sooner. So the length of stay in the emergency department was shorter when we used this Perc rule, probably because patients didn't have to wait around to get their CT scan. So overall, they felt like this was a really positive study. We could put this rule into place and make it better, safer, faster care for patients. Now, the second question I want to talk about with acute PE is, what if you do have a PE? How should we treat you? Sometimes that PE means that patients are pretty sick and they need to be admitted to the hospital. But often, patients with a PE could be safely treated at home. We can start them on an anticoagulant, especially one of the oral pills, and they could go home if they have good follow-up with a doctor. However, how do we actually make that happen? And there are a lot of barriers to making that happen. We know now that up to 50% of acute PE patients could be treated at home, yet in many hospitals, it's less than 10% of patients who are. That's a big gap. And the question is, can we close that gap? Can we find ways to help doctors and patients figure out who can go home safely? So that's really the goal of this next study that just got published last year. What they did is they took 21 hospitals in North Carolina, and again, they randomized them. They did half of them became what are called control hospitals, meaning they just let the doctors do what they had always done. But in 10 of the hospitals, they put this new tool in place. And this was a tool in the electronic medical record, so the computer system that the doctors used. That tool assessed how severe the patient's PE is. It advised the doctor on what the risk of dying in the next 30 days are, and made some recommendation as to whether the patient should be admitted to the hospital or whether they might want to consider outpatient management. And you can see sort of a picture of this on the right side of the screen, where patients who have this score, what's called the PESI score, that's pretty low, their mortality rate, their risk of dying in the next month is really low, and those are patients for whom we can often treat as an outpatient. The results of the study were really quite impressive. Before they made this intervention, in both groups, they had about 15–16% of patients were being discharged home. All the rest of them were being admitted to the hospital. In the group that didn't make any change to their clinical practice, there was no change in how many patients got admitted. That sort of makes sense. They kept doing what they've always done. But in the group that got that special intervention where this tool popped up in their computer system, they had a marked increase in the number of patients they sent home from the emergency department. They went from 17% all the way up to 28%. That's a big jump in the number of patients they discharged home. And it seems like those patients who discharged home did really well. They did not have a whole bunch of patients coming back to the hospital or dying. So it seemed like this was a really safe intervention that helped many patients avoid needing to be in the hospital. Okay, so now let's switch gears and let's talk a little bit about how we prevent cancer-associated venous thromboembolism, meaning a DVT or a PE in patients who have cancer. And I'm going to talk about two important trials from the last few years. So first off, there's this scoring system that we often use to figure out how high of risk a patient with cancer is for developing a deep vein thrombosis. This was named after Dr. Khurana, who developed the score a decade ago. So it's called the Khurana Score. And it asks things like what kind of cancer you have, what your platelet counts are, that's one of your blood counts, what your hemoglobin level is if you have anemia, what your white blood cell counts are, and whether or not you're obese. And if you add up those scores, patients who have no points, or even patients who only have 1 or 2 points, their overall risk of developing a DVT is pretty low. But once you get 3 or more points, then your risk of developing a DVT or PE jumps up quite markedly. So those are our highest risk patients. So this first study we're going to talk about, this was called the Evert Trial. Basically what they did is they took patients who were getting chemotherapy for their cancer and were at moderate to high risk for developing a blood clot. They were using that Khurana score, and they looked at people in the intermediate and high risk group. And they randomized them. They said, okay, half of you are going to get a sugar pill, nothing else. That's sort of the standard of care, what we usually do. But the other half of them are going to get a very small dose of a blood thinner. This was a blood thinner called apixaban. It also goes by the trade name Eliquis. Instead of using the normal dose that we often use in patients with AFib or a DVT, they used half of that dose, so a lower dose, hopefully just enough to prevent people from getting a blood clot. And they took this twice a day for 6 months. What they found on the left side of your screen is the patients who received apixaban, that's here in the blue line, fewer of them developed a deep vein thrombosis or pulmonary embolism over the next 6 months. In fact, they were able to cut the rate of DVT or PE by more than 50%. This number here is called a hazard ratio. It means we dropped the risk, so it was only 40% of the risk of somebody who got the sugar pill, the placebo. So it really had a pretty marked improvement in preventing people from developing blood clots. Now, of course, these patients were taking a blood thinner, so we have to look at whether or not they might have experienced some bleeding. And when we do look at patients who had significant forms of bleeding, the overall rates were pretty low. It was about 3% in the apixaban arm, so 3 in 100 patients got a major bleeding event, but that was twice as high as the patients who received the sugar pill. So overall, this trial said, yeah, we can definitely prevent blood clots in our high-risk patients, but it does come at the cost of a little bit of increased bleeding. Now, there was a second very similar trial trying to ask the same question. Again, patients who had developed cancer and were receiving chemotherapy here were randomized to either get that sugar pill or instead of apixaban, this time they got rivaroxaban. It's one of the other oral anticoagulants. Again, we give it at the half dose, so that prophylactic dose, not the full treatment dose that most people get. And they were treated for up to 24 weeks, so that's just shy of 6 months, and then followed for another 30 days. What you see here is, again, the patients who receive rivaroxaban, it looks like this blue line is lower than the people who got placebo or the sugar pill. Now, unfortunately, that difference was not statistically significant, meaning there is a chance that that sort of difference just popped up by chance and there was no benefit. However, what they found was that more than a third of patients who were receiving rivaroxaban, that's also known as Xarelto, more than a third of them ended up stopping their drug at some point during the study. And in fact, if you look at patients who just stayed on the drug, you do here find that those patients had fewer blood clots, and that was a statistically significant finding. In fact, almost the same reduction in risk as we had in the last study. So it seems like whether you use apixaban or you use rivaroxaban, both of them seem to reduce the chance of developing a blood clot in patients with cancer at about the same rate. So that's really great news. So the big take home here is that if you're somebody who has cancer, you're getting chemotherapy, and you're at moderate or high risk for developing a DVT or PE, that risk is pretty significant. It could be as high as 10% over 6 months, meaning 1 in 10 people get a blood clot. And if we give you one of these low-dose DOACs, we could probably cut that risk by half or even better. So it's really effective. However, that might come at the cost of some increased risk of bleeding. Now, thankfully, there were very few people who died from their bleeding, so it's not the most significant form, but we do need to be aware of it. Okay, so in the last few minutes here, we're going to switch gears a little bit and say, well, what about patients who've already developed a blood clot and they have cancer? What's the best way for us to treat them? And we'll look primarily at 2 different studies to help us out there. Now, first, I want to set the stage a little bit. Many of us know that Warfarin or Coumadin is the drug we've used for decades to treat patients who develop a DVT or a PE. Yet more than almost 15 years ago, more than 15 years ago now, we did a study called the Clot Trial. And this was in patients who had developed cancer-associated DVT or PE. And what we asked was, what's the risk of developing a new blood clot if we treated you with Coumadin or if we gave you an injection medicine? This one, they used a drug called dalteparin. Here in the United States, we often use a drug called enoxaparin or Lovenox. And what they found in this study, again, way back in 2003, is that if we used the injectable drug, we had a far lower rate of people developing new blood clots than if they used warfarin. So ever since the mid-2000s, it's pretty much been standard of care that if you have a blood clot and you're being treated for cancer, that we usually will favor the use of the injectable anticoagulant enoxaparin or Lovenox. And in fact, we repeated this study in 2015 and pretty much found the same thing. In this case, they used a different form called tinzaparin, but it's essentially the same thing as the enoxaparin or Lovenox that we use here in the United States. Lower rate of people developing blood clots than if they were on warfarin. So it sort of confirmed for us that that's really the best treatment for patients with DVT or PE in the setting of cancer. However, during that time, we also had all of these new direct oral anticoagulants coming onto the market. That's drugs like apixaban or Eliquis and rivaroxaban or Xarelto, 2 examples. So we started to say, gosh, could we use one of these new drugs, much easier because it's a pill, and would they do just as well in treating patients who develop a blood clot even though they have cancer? And so the first of these studies was called the Hokusai VTE study. This study took patients who had a confirmed DVT or PE and had known cancer, and they randomized them. So half of them got a low molecular weight heparin, so that's called dalteparin. Again, we would use enoxaparin here in the United States. And they would receive that treatment for up to 12 months. The other group only got 5 days of that injectable anticoagulant. Then they switched over to one of these new pills, one of the new direct oral anticoagulants. In this case, they used the pill edoxaban. It goes by the trade name Savesa. We don't use it very much here in the United States, but it's pretty similar to some of the other ones like apixaban and rivaroxaban. And again, these patients were treated for the same period of time. There was a second study that happened right at the same time, and it was almost identical. Again, cancer patients with a DVT or PE, they were randomized either to get dalteparin, that same injectable drug, or in this case, they used rivaroxaban. So that's the Xarelto medicine that many of us are familiar with. And this was called the SELECT-D study. So again, we have two studies, almost the exact same design, asking the same question. What you see here on this screen is sort of the main finding from both of those studies. On the left, which was the Hokusai VTE study, this is looking at the overall risk of developing a new blood clot or having a major bleeding event. And you can see that both the blue line here and the red dotted line completely overlap each other for the whole year that these patients were followed, meaning that there was no difference in the risk of developing a new blood clot or bleeding, whether you got the injectable drug or you got the pill edoxaban. So that's really good news. The pill seems to be just as good as our standard of care. Now, over on the right-hand side of the screen, this was from the SELECT-D study. In this case, the patients who got the injectable, that's in this case dalteparin, they actually had a higher risk of developing a new blood clot than the patients who got the pill rivaroxaban. So in this case, it sort of suggests that maybe the pill is even more effective than being on the injectable drug. I'm not sure that we would go all the way to saying absolutely it's more effective, but it certainly isn't any worse. So again, taken together, these two studies suggest maybe in our patients who have cancer and develop a blood clot, using one of these newer pills as an anticoagulant could be a good treatment option rather than having to give people an injectable drug like low molecular weight heparin, enoxaparin, or Lovenox. Now, one of the things that was really interesting is they did see a lot of patients had some bleeding. And that was a big concern about, is it safe to use these oral pills in patients who have bleeding? What they saw here was that the difference in your bleeding risk had a lot to do with what kind of cancer you had. If your cancer was a GI cancer, maybe a cancer of the esophagus or the stomach or the pancreas, those patients had a lot more bleeding when they took the pill. That sort of makes sense because the pill is an anticoagulant. You put it inside the body right where the cancer is, that's where they're likely to bleed. Whereas if you're using an injection, which often will go in your stomach, then it has to go all the way throughout your system before it gets to sort of where the cancer is located, less likely to cause bleeding right there. Now, if you didn't have a GI cancer, if your cancer was somewhere else, maybe you had breast cancer or some other form of cancer, there was really no difference in the risk of bleeding, whether you got an injection or a pill. So this really, for me, means that if I'm going to have a patient who needs to take a blood thinner because they developed a DVT or PE while they have cancer, my selection of using a pill versus an injectable will often be informed by what kind of cancer and where it's located, because I certainly don't want people to have lots of GI bleeding and then be in the hospital for that. So in summary, if I go back and cover everything we talked about today, a number of new trials that have come out in around the management and diagnosis of patients with venous thromboembolism. The first is that we now have some new strategies that can help us avoid unnecessary testing when patients are in the emergency department, especially if it's a low-risk patient. And if a patient in the emergency department is diagnosed with a PE, as long as all their vital signs are pretty stable and their risk of having a complication is low, we now have some strategies that can help remind doctors to think about treating those patients at home rather than admitting everyone to the hospital. For patients who have cancer and may be at risk of developing a DVT or a PE, this new class of oral anticoagulants, what I call the DOACs, they're probably a really good option for helping us prevent people from developing a DVT or PE. And if we can avoid that, that really helps, can save people's lives. It certainly makes them feel better, avoids a lot of complications. So that could be a really great strategy in many of our patients who have cancer. And if our cancer patients actually develop a DVT or a PE, now we have a good oral option. We can use these oral pills to help treat that DVT or PE. We don't have to rely on the injectable drugs for everyone. But it comes with the caveat that we need to know where their cancer is, because if their cancer is somewhere in their GI tract, they may not be a great candidate for the pill because we wouldn't want them to have too much bleeding. So I think this is just a quick summary of some recent studies that have come out in the world of venous thromboembolism. And with that, I'm happy to stop and take any questions in whatever time we have remaining.
All right, thank you so much, Dr. Barnes. That was a really nice summary of a lot of the new research that's come out around VTE. So we got two types of questions, some that are more specific to your presentation, and I thought we'd start with those, but we also got a few kind of more personal questions that if we had time, I'd like to get into as well. So the first question is there any research being done looking into genetic markers for an increased risk of blood clots? Or what about how to prevent blood clots entirely?
Yeah, those are two really great questions. And there are a lot of people trying to figure out why people develop blood clots. Sometimes we have a pretty good explanation why it happens, such as somebody might have been taking some hormone pills, or they were in a cast or just had a surgery. Maybe they got their hip or knee replaced. But often these blood clots happen totally out of the blue, and we're not really sure why. There are a couple scenarios where people are at increased risk for developing blood clots. Maybe there's a genetic predisposition, meaning something about their genes that sets them up. But oftentimes, in fact, the majority of the time, we really don't know why people develop blood clots. And so many people are doing research to try and figure out what are all the different mechanisms that may be contributing. My guess is that there may be some other very complicated genetic components that play into this, but it's equally or maybe even more likely that there are many other factors, a combination of environmental factors, just things about people individually, and that sort of contribute to this risk of developing a blood clot. So I do think we'll learn more in the next couple years. However, I don't think we're anywhere close to saying, gosh, we can come up with the answer for everyone. I would suspect for a good time moving forward, we're still going to often say that people have an unprovoked blood clot, meaning we just don't have a good reason why they developed it. And so a lot of the focus is on how do we treat people to prevent a second blood clot while often avoiding any of the complications that come with being on a blood thinner. And that's really where there's a lot of exciting research going on right now. There's a whole new class of blood thinners that are being investigated right now that we think might be really good at either treating blood clots or helping to prevent blood clots, and they might not have any risk of bleeding. Again, it's very early days, but there's some very exciting work suggesting that perhaps in the next decade, if this all pans out, we might have a whole new class of drugs we could use that for many patients would be effective and even safer. So I'm really excited to see what comes in the future.
Well, that is really exciting. I know that, we have online support groups around bleeding, and that's always, understandably so, a really major concern for patients and providers alike. So that would really be remarkable if that was kind of taken out of the equation.
Yeah, I agree. It's really an exciting area. Of course, we've often heard of really exciting things that don't pan out. So I'm certainly not going to hold my breath, but it's something that I've been keeping a really close eye on, because if it comes true, then these new drugs could be really effective. In the
Yeah.
meantime, I spend a lot of time talking with my patients about strategies they can use to try and avoid bleeding when they have to be on a blood thinner. And I think there are a lot of different things people can do to help out. I mean, it can be as simple as, remembering to keep your nose irrigated with some saline spray in the winter so it doesn't dry out and get a nosebleed. Or, talking to your doctor and asking, do I really need to be on an aspirin if I'm also taking a blood thinner like Coumadin or Apixaban or something like that? Because sometimes taking multiple blood thinners together are what really can cause the problem. So I think there's lots of other strategies we can use to try and reduce the risk of bleeding now while we wait and see if these new drugs are going to pan out.
Yeah, and you're absolutely right. Making those little changes can really be a big difference just in terms of, the quality of life and not having to deal with nosebleeds and stuff like that. So, those are really practical ways to kind of just prevent something from even happening. So I thought this was a really interesting question. But the patient said there's a lot of research that's being done on the new anticoagulants, the DOACs, but he's on warfarin. And he wants to know, should he be concerned that there isn't really that much research being done on warfarin right now?
Yeah, I think that's a really good question. And my answer to you would be no. And I would say no, don't be worried for two reasons. The first is these new anticoagulants, or what I call the direct oral anticoagulants, they've only been out for about a decade. So we have a lot that we need to learn about them. Warfarin or Coumadin, on the other hand, has been out for more than 5 decades. So we've had a lot of time to learn about it. Now, that doesn't mean we know everything about warfarin, but we really do know quite a bit about how it works, how to manage it, what its positive effects are, what some of its negative effects are, things like that. So in some ways, a lot of the research on the direct oral anticoagulants, we're just trying to catch up to everything we had already learned. The other reason I would say not to be worried is, yeah, if you read the press or if you read some of the big journals, the medical journals, they like to talk about all the new research with these newer drugs, but there's still a lot of people who are doing research on how to make management of warfarin even safer and more effective. Our group here in Michigan is one. We do a lot of work thinking about how do we make the management of warfarin safer. So I would say rest assured, it's not that people have totally forgotten about warfarin. Many of us are still trying to learn new things about warfarin and better ways to manage it. We may not get sort of the frontline press. We may not be on the front page of the news, but there's still a lot of good work happening. And anything we find, we rapidly share with any other anticoagulation provider across the country because we want to make sure that all patients get the benefit. And I think you'll continue to hear some new things about warfarin in the next couple of years. So keep your ear out. Good things are happening, but also rest assured that warfarin's a drug that's been out for so long that we really do have a pretty good handle on things so far.
Well, that's really reassuring. And you've kind of talked about this a little bit with the new drugs that, might not increase your risk for bleeding, as well as the work that your group is still doing about how to make warfarin even safer. But is there any other research happening right now that you're particularly excited about?
Yeah, there's actually a project that we're doing here. I can tell you a little bit about, and it has to do with warfarin and some of the strategies around avoiding bleeding. We have a set of data from 6 different anticoagulation clinics here in the state of Michigan, and we all work together to try and improve care for our patients who are on warfarin or any other anticoagulant. And we noticed a couple years ago that many of our patients who were taking warfarin were also taking aspirin. Yet they didn't really have a clear reason to be on aspirin, meaning they hadn't recently had a heart attack or a stroke or maybe had a stent in their heart, something like that. Reasons that people are often put on aspirin. So we looked and we said, if you're taking warfarin for a good reason, maybe you have AFib, maybe you had a DVT or PE, what's your risk of having a bleeding event and needing to go to the emergency department or get admitted to the hospital if you're also taking aspirin without any clear reason? And what we found is those patients who were taking warfarin and aspirin together had a much higher rate of bleeding, emergency department visits, and hospitalization compared to the patients who were just on warfarin without aspirin. And so based on that data, and we published that earlier this year in one of the journals called the Annals of Internal Medicine. We're really excited about it. I'm sorry, that was in JAMA Internal Medicine. We actually have started a program now where in each of our anticoagulation clinics, our nurses do a periodic review of the medicine. And if they see that a patient is on warfarin and is taking aspirin, but they can't find a good reason to be on aspirin, they'll actually contact that patient's doc and say, hey, do you think this patient really needs to be on aspirin or not? And just in the last year, we've been able to get many of our patients to stop taking aspirin when there really was no indication. And in fact, a bunch of research came out in the last year or two suggesting that, the benefit of aspirin is only in select patients. It's not a drug we want everyone to take. we really have to make sure that it's being used only for patients who have a really good reason to take it. And so we're doing some follow-up analyses now, but we're hoping that by reducing the number of patients who are taking warfarin and aspirin together, we can help to avoid some bleeding complications and help prevent patients from having to go to the emergency department or get admitted to the hospital. So I think that's a great example of a way we're still doing research around warfarin, how we're thinking about how we can deliver care to patients and make it better and safer, and just overall make anticoagulation care better for patients in general.
Wow, that's awesome. So it's definitely, if patients are on an anticoagulant and aspirin, it's worth having a conversation with your provider about, is that aspirin necessary?
I think that's absolutely right. There are many patients for whom being on, say, warfarin or apixaban in addition to aspirin is absolutely appropriate. And so I don't want people to come away thinking everyone should stop aspirin. That's not the case. But we do think that aspirin is probably being overused in many people. And so if you take a blood thinner like warfarin or apixaban or rivaroxaban, I think it's really important to let your doctor know if you're taking aspirin or if you're taking anything else like Motrin or any other sort of pain meds, because those are things that can affect the risk of bleeding. And you want to make sure your doctor knows about it so they can advise you on what's the safest strategy.
Okay, awesome. So now we have some questions that are a little less research focused and more specific to, I think, individual patients. But a lot of these, kind of themes we see a lot. So I think we'll dive into those now, if that's okay.
Absolutely.
So the first one is there a link between dilated cardiomyopathy and PE-DVT?
Yeah, that's a really good question. And my answer to that would be there's not a very strong link. There may be a very small link, but when we talk about patients who have dilated cardiomyopathy, meaning that the left side of the heart, the main chamber of the heart that pumps blood to the body, has gotten big. And often when it's gotten big, it's also weaker. So it's not pumping blood quite as vigorously as somebody with a normal heart has. There are a lot of reasons that those patients have problems. They often will develop pulmonary edema or heart failure symptoms, things like that. But people who develop blood clots in the legs, DVT, or in the lungs, pulmonary embolism, that's in the vein system, and it tends to not be affected as much by a dilated cardiomyopathy. Again, it's not an absolute difference, but they are not tightly linked in the same way, say, we know that patients who have hip and knee surgery or patients who are admitted to the hospital and lay in bed for 4 or 5 days, those patients are at risk of getting a DVT or a PE. Just having a dilated cardiomyopathy is not a big risk factor for developing a DVT or PE. It might have a small contributing component, but not a huge one.
Okay. All right. So the next question is from a woman who has a kind of complicated history. They were recently diagnosed with antiphospholipid syndrome. They have had factor V Leiden that they've known about for 20 years, but they just had their first DVT PE at 53 years old. Since the recovery from the DVT and PE in May, they've had chronic venous insufficiency that has developed while they're on warfarin. So they're wondering, is there a link or relationship between venous insufficiency and antiphospholipid syndrome?
That is a really good question. So let me break this down for people. So the antiphospholipid syndrome is a syndrome where the body starts to attack some of its cells. It sort of goes after fighting some of its own cells and leads to developing blood clots. In fact, people who have antiphospholipid syndrome are some of our highest risk patients for developing blood clots. So whenever somebody is diagnosed with antiphospholipid syndrome, we always want to make sure they're getting really good quality anticoagulation care, especially if they've ever had a DVT or a PE. Now, the question was, could the antiphospholipid syndrome be connected with something called chronic venous insufficiency, meaning that the veins that are in our legs, which are meant to bring blood from our toes up back to the heart so it can circulate, that sometimes those veins don't work properly. In fact, what happens is those veins all have one-way valves to make sure blood only flows in one direction, from the toes back up to the heart. But if those valves start getting leaky, blood starts to collect down in the legs. It goes the wrong directions, and then they start getting swelling, aching, maybe even varicose veins. Those are the types of things we see with chronic venous insufficiency. The reason that patients might have both antiphospholipid syndrome and chronic venous insufficiency, they're linked together because of deep vein thrombosis. So a patient who has the antiphospholipid syndrome is at higher risk for developing DVT. And any patient who's had a DVT, they've had a blood clot form in the veins of their leg. That blood clot can damage those valves inside the vein. And if it damages those valves, the valves become leaky. It's what we actually use the term called the post-thrombotic syndrome. What all that means is those are patients who have venous insufficiency, but it happened after having a blood clot. So post-thrombotic syndrome and chronic venous insufficiency are very similar or almost the same thing. It's just a matter of whether or not you've had a blood clot before. And that blood clot could be related to the antiphospholipid syndrome. So that's how they're all sort of tied together.
Wow, that's really interesting. Huh, very cool. Thank you. So the last question that we have is from a patient who was allergic to the first anticoagulant medicine that they were on and had relief with a third one that they tried from the various side effects. But they're still not totally back to normal. So they're wondering whether or not they should try a fourth anticoagulant. The one side effect they haven't been able to shake is severe joint pain. I guess the Coumadin they tried lowered their blood pressure a lot, causing them to pass out. Rivaroxaban gave them headaches, concentration problems, muscle weakness and fatigue. Eliquis gave them joint pain. So they're kind of, looking for, is it worth trying another option, or should they just kind of accept the lesser of all the evils?
Yeah, so that's a really great question. And this is the kind of question I see a lot in my clinic. And I'm not going to be able to give you a great answer because there's so many different nuances. But here's what I would say. Here are a couple general takeaways. The first thing we always have to ask ourselves is, why are we taking a blood thinner in the first place? Now, it's usually to prevent blood clots from forming, but what's the risk of that from happening? Sometimes we may say, wow, your risk of having a blood clot is really high. Maybe you've had multiple blood clots in the past. Maybe you have an underlying blood disorder like the antiphospholipid syndrome that sets you up. Maybe you have a history of atrial fibrillation and you have a bunch of risk factors that put you at risk for stroke. Or maybe you've had a mechanical valve placed in your heart. There may be a really good reason to be on a blood thinner to try and prevent blood clots. If that's the case, then I would say we should do everything possible to try and find a blood thinner that you can tolerate. Because if your risk of developing a blood clot is high and that blood clot's dangerous, we would really like to avoid that if possible. Now, there are other times where the risk of being on a where the risk of developing a blood clot might be relatively low. Maybe it's a young, otherwise healthy person who has atrial fibrillation, but their overall risk of stroke is quite low. Or maybe it's somebody who only ever had one DVT 5 or 10 years ago and has never had anything since. Those would be patients for whom the risk of developing a blood clot is pretty low, and if they're having lots of side effects to medicines, well, maybe they'd be willing to take the risk of the low risk of having a complication in the future, but avoid all the side effects of the medicine. So you have to sort of personalize that decision based on your individual situation. The other thing that I always talk about with my patients is side effects are a pretty challenging thing to nail down. There are some side effects we know about. For instance, people who use the blood pressure medicine lisinopril, if they start developing a cough and it's sort of a dry hacking cough, we know for sure that's related to lisinopril. That is really well documented. But many patients will develop side effects that we don't see over and over again. They're very unique or individualized. Sometimes they can be related to the medicine, but sometimes it's a symptom that patients have and they happen to be taking the medicine, but the two aren't necessarily linked. So in patients who I think really need to be on a blood thinner, I always encourage them to try multiple blood thinners and sometimes even go back and try it again just to see if that same side effect came up. Because you may have got some joint pain while you were taking, let's say, rivaroxaban, but if we went back and tried it again a couple months later, you may not actually develop the joint pain. The joint pain could have been coming from something else. And if that's the case, boy, it'd be really nice to know that you could take rivaroxaban safely. So I often will talk with my patients about sometimes doing a repeat test of their medicine just to see if that symptom comes back again. If it does, then that's a real side effect. Or maybe it doesn't come back and they just had those symptoms, but it was related to something else. So that's usually what I talk about with patients. What's the real risk of having a blood clot? And are they willing to retry some different blood thinners just to see whether the side effects are really related to the medicine or if they might have been coming from something else?
I think it's a really, kind of practical approach to this and really underscores the importance of having an open dialogue with your healthcare provider and making sure that you're being honest with them and keeping them in the loop, so they can provide these different solutions. To kind of help you work through these issues, because I think a lot of the times patients get frustrated and feel stuck. But there's healthcare providers are in this business for a reason. They want to help. So you should definitely push for other answers if you're not satisfied with how you're feeling.
Yeah, and I would add to that, I think it's really important to work with your healthcare provider as a partner. And so talk with them about the symptoms you're having. If they suggest something, say, okay, why don't we give that a try? And then I'll report back. And if that works, that's great. And if it doesn't work, what else can we try? And so really working together as a team, I think can be really important. So being willing to have that conversation, to talk with your healthcare provider as a team member and try and come up with the best treatment strategy for you. We may not always get it right the first or even the second or third time, but most of us really do want to work with our patients because we want our patients to feel better and we want to try and prevent bad things from happening. Exactly like you said, Catherine. That's why we went into this, is to work with people and try and make them as healthy and happy as possible.
And for those of you that are looking for a little more guidance on how to have these conversations with your healthcare providers, Dr. Barnes actually did a prior online support group for us where he covered that exact topic. And we have the recording of that posted on our website. So if you go to natfonline.org and then online support groups, we have them all archived there, so you can look for that one and take a listen, because I think it is really helpful to have those tools to have those conversations with your healthcare providers. So thank you so much, Dr. Barnes. You are just such a gifted teacher, and we're always so appreciative every time that you join us for one of these online support groups, and that you're so willing to donate your time to us and to speak with the patients. So thank you.
Well, thanks for having me. NATF is such a great organization, and I really appreciate all the work you do, and for all the patients who really want to try and make sure that they're getting the best care they can and that they're helping to advocate for other patients. I really applaud that, and so I really appreciate the opportunity to get to speak with you all tonight.
Okay, wonderful. And our next online support group is on October 1st at 7 p.m. And we're doing something a little different that we haven't done in the past. We're actually having a panel of doctors. So we're having Drs. Jean Connors, who is a hematologist at Dana-Farber, Dr. Greg Piazza, who's a cardiologist and vascular medicine specialist at Brigham and Women's, and Dr. Umberto Campia, who's also a cardiologist and vascular medicine specialist at Brigham and Women's, and they wanted to join together and dedicate this hour to really answering all your questions. So we encourage you, if you do have specific questions that you would like discussed, to submit them in advance using the info@natfonline.org email, or submitting them through Twitter or Facebook, however you found us. We'll also be taking them live the night of. So we hope that you can join us on October 1st. And in the meantime, I hope you all stay healthy and happy, and we will talk to you soon. Good night.